remember that tell your friends, tell your neighbors, tell people you're quarantined on your floor that Quiz 7 is 100% mandatory. Like, you have to have a score on Quiz 7. If you don't have a score on this next quiz, you'll be in bad shape because you're going to have a 0 on your average. That's not to say that Quiz 7 is going to be any different than any of the other quizzes that we've taken. It's going to be the exact same format, same everything. It's just that otherwise, for those of you who are just really doing well, if you could drop any of your quizzes, there would be no reason for you to continue to attend class. And I like you all too much and want you to I will force you to attend through the end of this, through the end of class. So make sure that you're, don't drop the ball on this. For a lot of you, this is going to be a low pressure exam. For some of you, between your previous scores and your research, if you score something above chance, like, you'll probably still lock yourself into a grade. But just make sure that you're on. You don't want to. What I've had before is I've told people, I'm like, okay, yeah, no, you just have to, as long as you get above a 50, you're good. You'll keep at your grade. And then people don't study and they come at like a 45 and then they're sad. But then I'm like, well, now you have to take the optional final. So just make sure that you're going through, doing everything that you have up to this point. You'll be good to go. Jacob, quiz dates are on the syllabus, but it's just going to be that last Wednesday of classes is when that'll be. So we'll go through, do some stuff, have break, come back, and it'll just be Wednesday sort of as it normally is. Okay. And then the optional final, that's set by the university. I think I've got the date on the syllabus. I'll go through and check at that just in case anybody is in a position where they would want to take the optional final. Any questions about anything up to this point? And where we're going with stuff? Okay. If you have questions and people have, said, hey, can you tell me kind of where I'm at with the course? That's email me. Happy to do that. With the way points are allocated here, because so much of the grade is attributable to your research and the extra credit and things like that. Again, what I don't want to do is put up on WIO courses, hey, this is your grade, because for some of you it'll freak you out because you're doing better than you think you're doing. For other people, you're going to say, sweet, I'm going to go get whatever I want and then not do your research, and then you're going to be mad when you don't get the grade you want. So that's why I don't have anything up there. But if you're curious, just get in contact with me. Let me know. Tell me how many research hours you're going to plan to finish with, and whether or not you have any unexcused no-shows. You can find this easy. Just look at your Sona account. Look for unexcused no-shows. Unexcused no-show just means you sort of missed something and didn't tell anybody. It's not a huge deal. I just give you a little bit of extra bonus if you don't have any unexcused no-shows, but that's the only impact there. So just let me know that, and I'll let you know exactly what you should be shooting for on this last quiz. Okay.
Can we still do research credits over a break?
Yeah, you can do. So right now it's kind of, I'm on our IRB for the university, and so it's a little bit tricky situation. Most of the stuff up to this point has probably been online. I don't know if anybody's done any in-person studies. Maybe a couple of you have. But yeah, you're free to participate in studies all the way up until, the 5th? Just the last Friday of classes. So that's your deadline to get all your research in. So long as you get it done by then, you're going to be good to go. Good question. Any other questions?
Dr. Clapp, on the note of research,
yeah.
I got an invitation for one yesterday.
Okay.
I'm not sure how the setup for the interview works, or the scheduling.
Okay. Yeah. Just go through and get in contact with the investigator, whoever sent you that email, and just they'll be able to help you out and tell you sort of exactly where you're at with that stuff. Sound good?
Okay.
Cool. All right. Madison, good question. For the optional final, can it hurt your grade or only help your grade? Optional final can only help your grade. I'm not going to penalize anybody for trying to improve their score. So if you go through and you take the optional final and you score lower than your second lowest score from quiz 1 to 6, then no harm, no foul. You're fine. It just won't count towards stuff. But if you go through and do now, in order to make that worth your time and effort, would sort of suggest going back through your notes and going through and thinking about questions that came up and getting that put together. But you can't hurt yourself. It's not like you're gonna take the optional final back. Well, that goes into your thing now if you bombed it. But just make sure that if you're gonna take it, study, prep, and what we'll do is we'll replace your second low score from quiz 1 to 6. Again, quiz 7 is in there. That's in there no matter how you do on quiz 7. But what this will do is it will replace your second low score. Okay. Other questions? These are good questions. This is important things for people to know. All right. Oh, is that another 40 quiz encompassing everything? Yeah. Jonathan, actually, it'll be 50 questions. So, and it'll all be questions you've seen before. It'll all be stuff from previous quizzes, right? So there's nothing new on that optional final. I'm just going to go through, pull questions from your previous quizzes, drop those in. It'll be 50 questions. But other than that, sort of looking pretty standard to everything else. Cool. All right. Feeling okay about this? Cool. All right. What we're going to do today is we're going to jump into some stuff looking at some clinical issues. I'm going to be honest with you. I've been faking it this whole semester. Anything that we've covered up to this point are things that are outside of my area that I know sort of only peripheral basic information about. This is so we're going to finish off with stuff I actually do know about. So this is stuff looking at clinical psychology in sort of my specific area. And so we're going to go through and talk about today how we think about psychological disorders. Okay, this is a tricky situation. And a really hot button topic, continues to be, has been for some time, right? So again, like we've done a lot of times, I was thinking about if we're taking a scientific approach to looking at phenomena, sort of first thing we want to do is to think about how we're defining things, right? And so how do we define a psychological disorder? What is a psychological disorder? This is something that we continue to not have 100% consensus across people in the field, right? And so depending on sort of the perspective, some different things that people have suggested in terms of psychological disorder. Now, going back through and taking a kind of a historical perspective, some people make the argument that this idea of psychological disorder is a bogus construct, right? The argument here is that what we label as disordered behavior, from a psychology, more kind of a psychiatry standpoint, just a label used to justify medical power, right? And ability of the government and health officials to intervene on any type of behavior that is deemed socially inappropriate, okay? And so for this perspective, people will make an argument, and sort of maybe less so today, but at definitely at the sort of turn of the century, 19th to 20th centuries, if you were doing something that people felt was no good or disruptive or inconsistent with social standards and things like that, you could be labeled as being mentally disordered, tossed into an insane asylum or a state hospital, and then just kept there indefinitely, right? Like this was something that did happen, for a long time, and even as early as homosexuality identified as a mental disorder as late as 1973, right? So this was identified as a socially inappropriate orientation, and so what we did is we said, well, if you're attracted to members of the same sex, then you obviously have a mental disorder, and so we're going to have that as a diagnosis that we can go through and label as a means of social control, right? And so this has really, really, particularly, in the early decades of the 20th century, this had a big impact, because if you were put in a state hospital, you essentially had no rights. If you were deemed insane, right, or mentally unable to sort of make your own decisions, what they could do is they could provide any sort of treatment they would like, right? Anybody ever heard of an ice pick lobotomy? Yeah, Brooke, you're nodding your head, I see. Can you tell me what an ice pick lobotomy is?
I don't know much about it, but isn't it where they kind of put an ice pick like up your eye and like tap it a little bit to get rid of some of the like frontal cortex?
Yeah, that's exactly what would happen, right? So lobotomy's been around for a long time, right? But lobotomy involves me cracking open your skull. That's kind of a big ordeal, right? What we had is psychiatrists recognize that, hey, you know what? Inside your eye, right there, right behind your eye, there's not much bone there that goes straight into your skull. And if what we can do is we can take something that looks like a thin ice pick, and if we put it in the corner of your eye, we work around your eyeball and just tap that up, break into that sort of basically where your frontal lobes are at, and just kind of scramble that around a little bit. Basically, we have lobotomized you and have some pretty serious results. Sometimes, if you've got a lot of disordered behavior or sort of impulsive behavior, that might fix it, or it might not. But I don't know. I really don't care, because you're a ward of the state and you don't get to have any decisions, right? Anybody seen One Flew Over the Cuckoo's Nest? Okay. Same type of idea here, right? Like you're in the care of the state, and the state can do whatever they want to do with you. Now, this seems like, oh, so this is probably only indigents and things along these lines. But Rosemary Kennedy, John F. Kennedy's sister, had some difficulties, right? So that had some acting out behaviors. It's not exactly clear what maybe had an intellectual disability, not exactly clear, but ended up taking Rosemary Kennedy to a psychiatric hospital where they performed a lobotomy because of mood swings, sneaking out, things like that, right? And so at one point in time, right, sort of this label of you have a disorder carried huge implications on your rights and what you can do. And so a perspective that still exists to some extent is thinking of social or disorder as a way to just go through and control people and sort of stigmatize or categorize them as problematic in some way. So, questions about sort of this kind of social control orientation? All right. So, but if we do identify and if we do accept that sometimes people experience certain types of behavior that are problematic and create difficulties for them, how do we go through and how do we identify sort of what qualifies as a disorder? And one approach that seems to be, on the surface, to maybe a reasonable and more objective sort of way to go about things is a statistical deviance criterion, right? And here what we're saying is that disorder is indicated by a statistical abnormality, right? So think about depression, right? Mood varies. Over the course of the day, over the course of a week, your mood will vary to sort of hopefully having some highs, maybe having some lows, hopefully lows that don't last for too long. But what we would say is from a statistical deviance criterion, what we would say is we would identify you as maybe struggling with an actual diagnosis of depression is if your mood was statistically different, sort of like in terms of the intensity and duration relative to what normal mood looks like, right? So as soon as we get things like anxiety or maybe say aggressive behavior or low mood or sort of some of these things that extends beyond sort of what's normal, then that's when we would go through and identify the presence of a psychological disorder. Okay. This isn't a bad criterion in theory, right? But where do we run into practical difficulties with this? Any thoughts?
It'd be the same criticisms as like was it qualitative research? It's all numerical.
Mm-hmm.
You kind of lose some of the more specific aspects of it.
Okay, yeah. So, Jonathan, I think you're right. That could be a problem. So, quantitative, right? So, statistical data is quantitative, right? And so, this taken in without any sort of removes context, right? So, maybe sort of my mood is low, but maybe there's a reason for that. That because I sort of lost a family member or something big has happened in my life, right? So, yeah, that's a piece of it, right? Also, who determines what's normal in terms of behavior, right? What's our criterion, right? If we're going to say disorder is indicated by a statistical deviance, that assumes that we have some beat on what's normal behavior, right? But in actual fact, behavior is quite variable, right? Like I don't know sort of who determines what's normal and sort of the basis to jump off of, and then also how far do I have to deviate from, even if I did have something that I could say, here's my benchmark for normal, how far off do I have to be before I start to get into something that I'm going to qualify as a psychological disorder, right? So in theory, some relative benefits, but problems in terms of we really don't have enough information about sort of normative behavior in any context to sort of go through and start to say, okay, this is a deviation, a statistical deviation from normal, okay? Other thing, too, are all statistical deviations from normal problematic? What if I have an IQ of 140, 150, right? I don't, but let's say I did. That's a statistical anomaly, right? I'm far above the mean in terms of something that I do have a good beat on what's average, right? And so we're all of a sudden we're talking about situations like intelligence, athleticism, artistic ability, personality, wide variability here, right? But just because I'm not typical doesn't mean that I'm a problem, right? And so just taken in all by itself, this statistical deviance criterion starts to fall apart, right? Just because something's not typical doesn't mean that it's a disorder. Okay, so we don't like that, maybe. This is an interesting criterion that's come up or has been proposed, thinking about psychological disorder as consistent with harmful dysfunction. Okay, and here the idea is that proposes we'll identify a disorder when we see one, a system failing to perform a biologically intended function, and two, that failure is resulting in harm as determined by the standards of an individual's culture. Okay. So what's interesting about this approach is it starts to get at, Jonathan, some of the things that you had talked about, right? Some of the context, right? So a behavior here in the U.S. might be considered problematic for sort of white majority culture, but if I'm in a completely different culture, in a different area, in a different society, that same behavior maybe isn't problematic, right? And so recognizing that if I'm here in the States and I'm telling people that I am seeing visions and sort of am being sent prophecies and things like that, that would generally be identified as strange and problematic. But if I'm in a different culture, that could put me in a position to be sort of quite revered, depending on sort of the makeup of sort of wherever I'm at, right? And so recognizing that some of the things, sort of that cultural background, starts to become important in sort of identifying when things are going on. Okay. But if we're looking at this, what might be some concerns people have with respect to this harmful dysfunction criterion?
Who's to say what exactly is harmful?
Yeah, right? And we get into that sort of trying to figure out where that harm marks and how much harm it has to cause before we start to identify it as problematic. Yep. What about sort of this idea of a system failing to perform its biologically intended function? Okay. Or maybe some of you bio majors out there, right? So we've got lots of systems, lots of biological systems. Do we always have? Can we say for certainty what the biological function is of any given system? Starts to become difficult, right? When we go through and we see that we have biological systems that do stuff for us, but it's hard to say that that was the intended purpose of that system, right? So if we go back through sort of paleontology, sort of evolutionary bio types of things, right? Looking at the development of feathers in birds, right? All right. Well, feathers help birds fly, but hypotheses that originally maybe those feathers were intended to provide warmth, right? And flying was just kind of a side effect of that, right? For humans, thinking about our ability to read, right? Hannah, if you can't read, Hannah, how old are you?
18.
Hannah, if you can't read, that's a problem, right? Particularly if we've tried to teach you to read and you still can't read, that would be a problem, right? But do you have inside of you a biological system that's sole purpose was the development of reading? Probably not, right? Reading's probably sort of a byproduct of some other basic cognitive skills, right? And so the harmful dysfunction criterion starts to become, it's interesting, it's an interesting perspective, but it sort of predicates everything on assuming that we have a biological function and a system for sort of everything that we have going on, right? And so this sort of starts to break down on closer examination. Okay. People have questions about this harmful dysfunction criterion? It's a little bit different. Okay. So what we have, and this isn't sort of everybody, but this is for around the globe. If we're looking at our DSM system here in the States or the ICD-10 in other parts of the world, what we're generally identifying as a psychological disorder is something that ends up producing a combination of distress and or impairment. Okay, this is our criterion for almost every single psychological disorder that we recognize, saying that disorder is indicated when a condition results in excessive distress and or functional impairment. Okay, so if show of hands, give me a shout out if you're socially anxious. Okay. Okay, there you go. Thank you, the person who said that. I got you all off video right now. So, but yeah, social anxiety is very, very common, right? If you're a human being, right, and you're a normal person, there are probably some social situations that make you anxious, right? But at what point do you have social anxiety, right? Now, if we were working in, I would say, does this get to a point where it's causing you either excessive distress, right, where your social anxiety is causing chronic subjective negative emotions, right, or if it's causing functional impairment. If you can't call to order a pizza, or you can't introduce yourself to somebody, or you can't talk to your professors, or introduce yourself to other people, that starts to become impairment that we would identify as consistent with something that might be a disorder. Okay, so we've got here this kind of two-pronged approach. If we've got stuff that causes both distress and impairment, then we've got something that qualifies as a problem. If it doesn't cause distress or impairment, then it's hard to call this a disorder, right? So I do work with anxiety and trauma and things like that. You know, sometimes people have panic attacks, right? I would guess that probably someone, at least one of you out there, has probably experienced a panic attack at one point in your life, right? Panic attack, that's no good, right? That's super uncomfortable, right? But if you have panic attacks on occasion, but you don't really worry about it because you know what they are, like, yeah, sometimes my body just kind of blows up. I have a panic attack, not concerned about it. happens sometimes, it doesn't keep me from doing anything that I would otherwise do, then I wouldn't say that that's a disorder. I would say you have symptoms of panic disorder, right? You're definitely having panic attacks, but if you're fine with them and it's not causing any impairment, you're not worried about it, it would be hard for me to give you a diagnosis of panic disorder because we haven't met distress and impairment criterion here. Okay. So this is what we use. This is our tends to be our criteria for disorder. What are the concerns, though, or weaknesses about this distress and impairment criterion?
It would depend on the situation, the person you're meeting. Let's say if it is social, it would depend on the social setting. Or if you're introducing yourself to someone, it could depend on your perception of that person. It's not universal.
Yeah. It starts to be very specific, right? And, when we're doing these types of diagnoses, we go through and take into account, right? Like, how specific is this, or how widespread it is for social anxiety? If I'm pretty good, except for I have a problem in just this one area, seems like a pretty circumscribed field. Doesn't mean that you couldn't meet criteria, but it would be a different thing than if I can't talk with anybody ever, right? Worked with a person one time who was functionally sequestered in their parents' basement, and this was someone in their late 20s, just because they really just couldn't interact with even friends or even family members outside of mother and father and things like that. Really crippling social anxiety, right? That's obviously no good, right? But what if I make it okay, and there's just some areas where I'm a little nervous about, I don't like it, but I'll go through and do it. We start to get into problems, right? Or what ends up happening is where we go through and say how much distress is enough distress to cause to label a disorder, or how much impairment is necessary before we identify impairment, right? It starts to become kind of subjective, right? So two different people, you could go to two different clinicians, and two different clinicians could come up with completely different ideas on whether or not you met criteria for some sort of disorder, just based on, there's just a lot of fuzziness in this, okay? So the distress and impairment criterion is what we use, but it's still not by any means a perfect system, and we start to get into problems with sort of reliability of diagnoses and things. Questions about any of this? All right. Oops. All right. Other issue that we run into when we're thinking about psychological disorders, this idea of whether or not symptoms, we should be thinking about these as categorical entities, or whether or not these are sort of more continuous gradients of severity. Okay. So our Diagnostic and Statistical Manual of Mental Disorders, DSM-5. I've got one sort of back on my shelf right here. DSM-5, this is our book, contains a lot of different diagnostic entities, right? And whether or not you meet criteria for any of these given diagnoses based on some set of symptoms, some specified symptom threshold. If I meet, 1, 2, 3 symptoms for this disorder associated with distress and impairment, then yes, I meet criteria for alcohol substance use, or depression, or generalized anxiety, or bipolar disorder, sort of whatever, right? But what ends up happening is these criteria are applied to be categorical, right? Either you meet criteria for major depressive disorder or you don't. Either you meet criteria for PTSD or you don't. You meet criteria for social anxiety or you don't, right? It makes it sound like these disorders are categorical in nature. We have the haves and the have-nots. I've got this condition or I don't have this condition. Clear cut, this group is very different than this group. Okay? In actual fact, almost all of the diagnoses that we recognize can probably be categorized as existing on some continuum of normative behavior. Okay, and so what we get is this cutoff, this symptom criteria that we use for disorder to identify a disorder, largely arbitrary. So let's see so what we find is that if I'm looking at levels of distress in individuals who just don't meet that diagnostic criteria and that cutoff, are oftentimes functioning as badly or worse than people who go through and do meet. Okay, so if we're thinking about, let's take depression, major depressive disorder as an example here. So we've got 9 symptoms of depression. We've got depressed mood, loss of interest, disruption in eating, disruption in sleep, sort of attention decision making, suicidal ideation, guilt and self-blame, psychomotor disruption. Something else. There's another one in there. Anyway, okay. So we've got 9 symptoms, right? And what we need in order to diagnose major depressive disorder is we need at least 5 symptoms occurring more days than not, five symptoms occurring nearly every day over the past 2 weeks. Okay, and if you do that, we say that you meet diagnosis for depression. Okay, and so what we say is either you meet diagnosis for depression or you don't. Sounds like a categorical issue, right? And if we have people sort of down here on one end or down here on the other end, that categorical thing kind of works, right? I've got someone who meets no criteria for any depressive symptoms on any days over the past 2 weeks. That person is clearly fine. We have on the other side someone who's incredibly impaired, is meeting all criteria nearly every day for the past month. That person is over there. This person can't get out of bed or function or go to class. This person is perfectly fine. Then it's easy peasy, right? We got someone with major depressive disorder, someone who doesn't have major depressive disorder, right? But sometimes we get people who are right up against that edge, okay? Jacob, maybe you need 5 criteria, right? And those symptoms need to occur nearly every day over the past 2 weeks. Well, let's say you have 4 symptoms that are occurring nearly every day over the past 2 weeks, but then you've got a 5th symptom that just occurs about half of the days, okay? So technically, you don't meet criteria for major depressive disorder. Does that mean you're doing A-okay? No, right? You could be having a very, very difficult time, right? Now, if I were just looking at the category, I say, well, Jacob doesn't meet criteria for major depressive disorder, right? Jacob might be not doing very well at all, right? And if we're looking at someone, Brooke will use let's say Brooke, you do meet 5 criteria nearly every day over the past 2 weeks, right? So yeah, you tip over. But Jacob, on the other hand, for the past 6 months, has had 4 nearly every day for the past 6 months, but 1 is just kind of on and off. I'd make an argument that Jacob's probably doing worse off than you are. But Jacob doesn't meet. You do, right? If we're just thinking about this categorical system, you have major depressive disorder. Jacob doesn't have major depressive disorder. We treat those as categorically different when, in fact, sort of it's an existing on this continuum, okay? And so this dimensional approach, right? Almost the vast majority of disorders that we look at and sort of diagnostic entities that we look at are probably best thought about on this continuum, right? That this behavior is falling somewhere on a range of sort of normative behavior, right? If you think of alcohol, substance use, right? Or even something like, Oregon just legalized or decriminalized hard drugs, right? So even if we're thinking about something like sort of opiate use, sort of like heroin use, right? There are probably people out there who sort of use heroin recreationally with little impact on their lives. Probably not a great plan, right? But there's certainly cases out there, right? And so we're thinking about sort of where do we go through and take a look at this, right? Like you could say, oh, well, I'm a heroin user, I'm not. I mean, you can sort of talk about that as a diagnosis, right? And certainly if you're using heroin, you're probably much higher risk for a bunch of negative outcomes than you're not, right? But thinking about even things like sort of illicit drug use like that probably continue on a normative range of behavior, right? So outside of things like some schizophrenia spectrum disorders, right? Some forms of antisocial behavior. These are a couple of different conditions that look like it's kind of an either or, right? Like psychosis doesn't look like it works on a continuous range. Like, oh, I got a little bit of psychosis. It's sort of like sort of if I sort of prone to that. Like there's definitely severity there, but it's not sort of on this sort of general continuum. Same thing with some antisocial personality types of things. But for the most part, most of the stuff that we look at and take a look at probably better thought of as a continuum as opposed to this categorical yes, no piece of things. So I got a question in the chat. Does the amount of time of someone has had a disorder affect how easy it is to treat? Yeah. Megan, we'll get to that when we get into some mood disorder stuff like that. We start to see correlations between duration and onset as a correlate of treatment prognosis. For depression, right? We know that people who struggle from depression early on are much more likely to continue to have struggling and sort of subsequent episodes sort of moving forward. And so thinking about that as more of a chronic difficulty versus I just turned 40, right? If I had a depressive episode at 40 and had never had a depressive episode previously in my life, hadn't really struggled with down mood, then probably my prognosis for sort of subsequent episodes and treatment would probably be better than someone who's struggled with sort of depression since adolescence or something like that. That's not to say that person's doomed. It just says that is probably a longer stand. So the vulnerabilities towards depression and depressed mood is probably stronger for that person. And so someone in that situation probably needing to be more aware and conscientious of mental health and sort of staying up on stuff and sort of recognizing the types of things that might start to trigger them down into some depression stuff. So again, but I think this sort of gets at sort of thinking about this as a continuum from not everybody who meets criteria for disorder is all the same, and the people who meet criteria for disorder aren't necessarily categorically different than the people who don't meet criteria for disorder. A lot of variability in here. Other questions? All right, cool. Oh,
someone did just send another one.
Oh yeah. What level degree does someone need to be a clinical psychologist? There's lots of. If you like school right now and you want to be in school for a lot longer, so that's kind of what you want to do. So these are doctoral level programs that have additional stuff sort of tacked onto it. So if you want to work as a clinical psychologist, we're looking at PhD level stuff. But if you're wanting to just do mental health treatment, sort of there are some other options there. If you have a question, sort of get in touch with me and I can kind of lay out what that looks like. Cool. All right. Other question. Our psychopathology, our mental health conditions, are these consistent across cultures? Kind of depends, okay? What we see, like pretty much everything else that we've talked about up to this point, sort of this interaction of nature and nurture, right? Culture, genetics, combining to determine the presentation and the prevalence of different types of conditions, right? What we see is depending on what type of condition we're looking at. If we're looking at schizophrenia, okay, schizophrenia is a major, a serious mental health, serious mental illness, or is qualified as a serious mental illness. And schizophrenia looks pretty similar regardless of where you're going, right? So if I have symptoms of schizophrenia, it doesn't matter if I'm in China or India or the US or Norway or Nigeria. Schizophrenia looks like schizophrenia no matter where you go. Really, really strong genetic component to schizophrenia, bipolar disorder as well. Two of the conditions that have some of the highest heritability and genetic components going on, right? And so core features of schizophrenia look very, very similar across the globe, right? But what we see is we start to see culture starting to have a big impact on on what prognosis looks like and functioning looks like for people with schizophrenia, okay? So if you had, let's say, God forbid, you come down and so you start to experience symptoms of schizophrenia, right? Would you rather be here in the U.S. or let's say a developing country, say like India? Where do you choose if you want help and treatment for schizophrenia?
US.
What's that? So Kylie says the U.S. Jacob, what did you say?
I agree.
Okay, right. You would think that, right? So we think sort of greatest healthcare system in the world, so on and so forth, right? You'd be wrong, right? Prognosis for individuals with schizophrenia, sort of major mental health issues, start to look better in developing countries, places like Nigeria and India. Okay. Any thoughts on why that might be?
I feel like developing countries are better able to adapt to what is and kind of formulate what could be, kind of thing. Like, I feel like U.S. medicine will probably be set in its ways,
Okay.
considering certain things,
Okay.
more
Yeah.
open-minded to different treatment.
Okay. So Jonathan, I think you're starting to get close, right?
The level of cultural acceptance is going to be different. So in a developed country like the U.S., neurotypicality is ideal, whereas there's more flexibility and different perspectives on disorders in different cultures.
Yeah, that plays a part of it. Yep. And then also family structure and culture, right? U.S. and sort of European countries highly individualistic, right? And so if you look at the rates of serious mental illness and the homeless in our country, it's through the roof. It's way high up, because if in this country, right, if I start to sort of have delusions and start to have hallucinations, and I can't maintain jobs and care for myself, oftentimes that means I'm on the street, right? However, in sort of more collectivist countries, right, if the family stays together, and this is just in sort of there's this sort of more collectivist approach, then those individuals who maybe come down with serious mental illness issues, they're already integrated with the family, and so prognosis for those individuals tends to be better here because there's more of a family, a cultural safety net there, right? So if my brother struggles with schizophrenia and will have episodes where he starts to have some positive symptoms, and just sort of the negative symptoms are actually the worst piece of this, and he's not able to go through and hold down a job and things like that, he's there, the family's there to go through and sort of help and support and things like that. So this combination of sort of a lot of cultural issues helping to mitigate the potential negative impacts of these of some of the outcomes we see for serious mental health issues better than sort of in the U.S. and some of Western cultures, and just a straight up functional culture, right? So we see this combination coming together to start to predict prognosis and outcomes in many countries, right? So this is schizophrenia. And schizophrenia, like I said, a huge biological component to this, or a huge genetic component to this. But if we're looking at things like depression, okay, see huge differences in the presentation of depression and cultural influences on the presentation of major depressive disorder. If we look at lifetime prevalence across cultures, pretty low in places like Japan, pretty high here in the U.S., right? And we also see that depression looks different depending on where we're at, right? For European countries, okay, so the kind of Western European countries, what we typically see in terms of the presentation of depression, very strong and heavily oriented around guilt, suicidal ideation, that self-depreciation, and this sort of despair, right? I'm depressed, I'm no good, there's nothing good for me, I have no one to care for me, I'm having thoughts about ending it, and I feel guilty that I'm sort of dragging everybody down with me, type of thing, right? That's the typical presentation of depression in Western society. If we look at non-Western societies, though, non-European societies, we see a lot more of a focus on somatic complaints, right? So I'm having disruptions in my appetite and my sleep. I'm experiencing symptoms of fatigue, reporting different types of physiological distress, right? Again, with cross-cultural research, what we found is that's what you're talking about is depression, right? But it's just depression that looks different and is experienced in a systematically different way in non-Western cultures as opposed to Western cultures, right? And so, depending on what area we're looking at, some of these having mania looks the same across the globe. Schizophrenia looks the same across the globe. Different types of anxiety and depression, though, varies widely by culture, right? Again, suggesting that culture starts to go through and play a big part in how we experience some of these difficulties. This is why cultural context is important when we're going through and taking a look at assessment and diagnosis, thinking about sort of the backgrounds of where people are coming from and the types of things that they're experiencing, and sort of their presentation of this starts to come in and play an important role in how we go through and sort of say, yeah, I think this is the thing that's going on. Okay, so if we're thinking about cultural identity, right, thinking about culture, race, ethnic background starts to impact sort of how some of these symptoms can start to impact social relationships, whether or not these individuals are able to access resources, different types of functional challenges, and things along those lines, right? So again, going back to Jonathan's point, taking into context sort of this person's sort of, even if we're doing a diagnosis or treatment here in the U.S., taking into account someone's sort of more focused cultural background, where they're from, and thinking about how that impacts whether I do things, whether or not I can't do things, where I sort of do things day to day, stuff along those lines, right? And so while important to do this, if we're going to do a comprehensive assessment, also recognizing that background doesn't have a one-to-one relation with individual identification, right? Some of you out here right now may have come from families who immigrated to the U.S. or sort of were born elsewhere and coming in, and even though you may come from a certain background, you may not identify with that background a whole lot, right? And this is the tricky balance we have to walk as clinicians, right? There's something called a culturally encapsulated therapist, right? So to this idea, let's say someone comes in and says, oh yeah, no, I'm sort of identifies or sort of marks on a demographic sheet as Hispanic, Latino background, something like that, right? And say, oh, well, this person is from a Hispanic background, so this is how they interact with family, and this is how they do this, and this is how they do this, or this is how they do this, right? Or someone identifies as Chinese American, like, oh, I know about Chinese Americans, this is how they do it, this is how they do, this is how they do. Good to be thinking about that. Not good to just unilaterally apply that to someone who might not identify with that and might say, no, I'm sort of very much sort of Americanized, sort of Wyoming, right? I understand that. So recognizing that that it's important to think about this, but recognizing that there's not a sort of one-to-one effect in terms of things. We want to be careful that in our efforts to be sensitive, that we're not applying stereotypes that may not apply to people. Okay. Other thing we need to think about here is how communities may experience and communicate different types of distress, right? And again, going back to sort of the presentation of depression, right? Cross-cultural research tells us that in some communities, I'm unlikely to report that I'm feeling depressed, or that I'm sad, or that I'm upset about something. What I may do is I may experience or present with these symptoms more along a physiological, so kind of a somatic thing, right? A lot of health complaints may be fatigue, lost weight, increased weight, so the more physiological oriented types of things, right? And recognizing that can be a way that sometimes things are communicated, right? Even if, even with our own, even the U.S., right? This is a thing I fight with all the time. Right? Someone will come in and say, "Oh, how's it going?" Sort of blah blah, talking about something. Someone say, "Oh, I'm depressed," right? Depression is something that we've sort of come into our lexicon, right? And so if someone says I'm depressed, I don't automatically assume that they mean that they're struggling with clinical depression. I might sort of that might just mean that you're kind of sad right now, right? Or, oh, I'm so bipolar, right? What I'm assuming is that maybe you are using that to mean that you experience some difficulties, some ups and downs in mood or some strong emotion, not that you literally have a bipolar disorder. That's a completely different thing, right? And so recognizing that how people go through and communicate distress can vary from culture to culture, person to person, and making sure that we're not, because that's the wrong thing to do. You go into your doctor and say, hey, I'm feeling so bipolar, and you end up on mood stabilizers and stuff like that when you don't need it. So hand out stuff like candy. That's a different soapbox for a different lecture. So, but we'll end there. We'll pick up last couple slides here on Monday. So, all right. Any questions about any of this stuff up to this point? Folks feeling okay with this? Okay, awesome. Enjoy your weekend. Stay healthy. It's a damn landmine out there in terms of COVID all over the place. Travel safe. If you're going home for pre-Thanksgiving, we'll be same time, same place throughout the rest of the semester. But let me know if you have questions about where you're standing and things along those lines. Or if you have questions to ask after we sort of finish up here, so I'm here to help out. So, all right. For those of you taking off, we'll see you later.